We're going to allow, go ahead and get set up for it. What we're going to prepare for is the next segment of our day. Who here has seen a CyberMed clinical simulation before? Okay, raise your hand if you liked it. Keep it up if it kind of scared you. Okay, good. This is what we are well known for. So what's happening right now is we are streaming this George Washington Simulation Center, which is across the street. Literally a big white building across the street. This is live right now. We are preparing a simulation for you to witness live. And what I like to say is that this is an experiment every time we do this. Why is it an experiment? I don't know what the outcome is going to be. There's a lot of unpredictable elements to it. So what I'd like to do is just introduce what a clinical simulation is. And it's part of how we train doctors, nurses, other clinicians to take care of sick patients and do so in a safe way, a safe environment. So they're not doing that for the first time with a real patient. So we build simulation centers. These are places that look like real clinics. As you can see, that looks like a hospital bed, but it doesn't take care of real patients. Instead, it teaches clinicians on how to take care of simulated patients. These are actors and actresses who will learn what a patient looks like when they have a particular disease. They will have their body react in the way that a real patient with a particular disease would, or they'll put a rash on, they'll paint a rash on their body so that the physician has to find it, come up with a diagnosis and treat appropriately. We can do these in these simulations as a way to reduce the stakes, if you will, of treating a real patient for the first time getting it wrong. So we do these simulations over and over in medical education. I did a simulation every week, essentially, when I was training in emergency medicine. It's an experiment because a lot of things can happen. You're going to see a doctor, an attending physician, trained in emergency medicine, go into this simulation not knowing what these simulated patients have, not walking in cold. They are going to talk with this patient, examine them, order tests just like they would in the emergency department, come to a diagnosis and treat them. Along the way, I promise you there will be twists and turns. We don't know what that clinician is going to do. My job is to give you a little bit of a play-by-play for those of you who are not very medical. Because there's going to be a lot of medical jargon. They'll be talking about drug doses. They'll be talking about all these CT scans, all these different pathologies, and I'll do my best to walk you through that. And so what we're doing right now is preparing for that. On the left side of your screen is a vital sign monitor. I'm going to go ahead and turn down the lights a little bit so you can see. And the patient's vital signs will change throughout the simulation depending on what condition they may manifest. You'll be able to hear them talk. The case will unfurl. And then what we'll do is we'll bring the attending physician who we just tortured back over here in front of you to ask questions and do a debrief. So I would encourage you throughout watching this to collect some thoughts about what were you thinking? How did you figure this out? How did you feel when this happened? And put those in your pocket to ask during the Q&A at the end. So as we're waiting, we're just getting the last little details together. Yeah, questions?
Do the physicians know that this simulation is tied to the CyberMed summit?
Yeah, so we try not to tell them that this is a cybersecurity summit. It kind of gives it away a little bit. Wait, you want me to do a simulation at a cybersecurity conference? I think I know what's going to happen here. Sometimes it's hard to blind them from that. It's true. What other events are going on today? And some of our volunteers wear t-shirts. But we've done these simulations quite a few times. And despite them maybe knowing a little bit about what's going to happen, it's still always a little different. Great question. Any other questions?
I got one.
Yes.
You guys, I think pre-pandemic did something in blackout. This was just you guys, not necessarily physicians. So this is the same type of scenario.
Great question. So they're referencing. Absolutely. There was a question about a prior presentation we did at another conference, and whether or not this is similar. It's kind of similar. What you're referencing is that we did some simulated attacks on HL7 and some integrity attacks, similar, but slightly different. In this case, the subject, if you will, of the experiment, the attending physician doesn't know what's going on. So we'll see how they react. Any other questions? All right, I'll see if they're ready to go. Yes, another question.
Do you have any of your past simulations rather, public facing, that people can just go to a URL? Does that exist already?
Great question. The question is, are these simulations publicly available? When we wrote these simulations, we thought it was very important for us to share them with others. So all of the simulation cases themselves, how to run these, are published. So anyone can go and take these cases and go and run them at their own simulation center. In fact, we've encouraged that. One of the things that we'll talk about later on today is the need for education around this. And we find these types of simulations can be very useful in educating clinicians about this. There are some videos available of us doing some of these simulations that are publicly available on YouTube, and we can share those after. And we'll also recording these, and they'll be available on our website as well. They are published, I believe, in the Journal of Emergency, the Journal of Emergency Medicine.
Yeah. Disclosure vulnerable.
Okay, we're doing a sound check. Anyone here? Can you speak up? No.
Try again.
We wouldn't be a CyberMed without last-minute technological issues. I think we hear you now. We can hear you now. Correct. You think after 2 years of the COVID pandemic, we would know how to use Zoom.
Simulation.
You have a question?
I don't want to dominate the question, please.
Oh,
I was just wondering, again, from a public education perspective, is the simulation that we're going to see now different materially than ones that you currently have on your website?
this one I don't believe is on any publicly facing website, this particular case. So we write these cases and we base them off of real diseases. We base them off of real medicine. We don't, we find it that it really doesn't do a good job of convincing clinicians if you build a case that's unrealistic. We also pick cases, typically speaking, that are very time sensitive. If we were to do this in, for instance, a clinic appointment, you go see your primary care doctor and they can't log into electronic health record. It's not a time sensitive medical condition most of the time. So most of our simulations involve things in the emergency department or in the operating room or in the ICU. Those types of things are really what we focus on because that's when minutes matter. That's when acute life-saving treatment needs to be done and delivered now, as opposed to in an hour or two. Great question. Any other questions? Yes. Yes, this is an emergency room. We'll have an emergency medicine physician and a team of simulated nurses and technicians that will be executing the roles that you typically would see in an emergency department. They're all in on it. They know how the case is going to unfurl. The one who doesn't know what's going to happen is the doctor in the case. Great question. So the question is, do the published simulations have the technical details as well of the particular, I'm assuming you mean the security technical details. Absolutely. So all of our cases are not only based in medicine, but they're also based in real security research or something that we've seen happen in reality. We don't make up a medical device and make up a fake vulnerability. We use the source research from the security researchers and or the hackers themselves to craft what would happen. The technical details are not contained within the simulation. Those are often reported by the researchers themselves when they go and present a vulnerability on an infusion pump, for example, or an insulin pump. They'll do their presentation talking about the technical details. They may or may not release things like proof of concept code, but that's a great question.
If I actually wanted to run the simulation, how do I get the computer in the simulation room to look like this? Have that part.
Oh, yes, that's all contained. Sorry, forgive me. So it was the details of the simulation case to involve how to replicate those kind of technical details. There are some details, they're not very verbose, but that's a great suggestion for some improvement what we really want to do is show these to the world, right? And the best that we can do to package them in an easily executable way so that any simulation center across the world could do this, that would only help amplify this message. So that's really great feedback.
I'm just looking, yeah, hey, I'm Fran O'Connell, nice to meet you. I'm wondering, do we have hand gel? I guess, are we worried about sanitizing here? And if not, yep, is that what we got? Yeah. All right, cool, thanks. Hey, Dr. Connell. Hey.
How's it going, man? These
Good.
night shifts are tough.
Yeah, they are. Hey.
I'm Jeff. I'm new at this hospital.
Great,
I don't
Jeff.
think we've worked together before. I'm gonna be your nurse for today.
Okay.
But I'm really tired, so I'm kind of hoping that we have a slower shift. I know it's not that common to say that. But yeah, I haven't heard of anything yet, so we'll just kind of make sure everything's ready to go for whoever rolls in, but hopefully we can just kind of relax.
So tell me a little bit about you, in terms of like your background.
Yep, ER nurse, been doing it about 10 years now, kind of bouncing around the country, how
Yeah.
We have an EMS patch coming in.
All right, I guess, here we go.
Maybe not a
EMS to Hospital 8.
Yep, this is Hospital 8, go ahead.
We're coming in with a 73-year-old male, left-sided hemiparesis and right-sided facial droop for the past 3 hours. EKG shows AFib, GCS of 14. Got some vitals for you. Blood pressure is 155/80, heart rate's 85, respiratory rate is 16. We got a temp of 36.5. ETA is about 2 minutes.
Okay, All right, ETA is 2 minutes. Do you have a blood glucose?
We're working on it, sir.
Okay, no problem. Thanks so much. We'll see you when you get here.
What time gets up for you?
So, I think probably we want to get some airway stuff.
Okay.
It looks like our Zoll's ready to go in case, but we can hook up pads if that's okay.
Okay.
It looks like we got suction here. One of the things that I'm thinking about is this is somebody who's gonna be, maybe need to be intubated.
Okay.
May need TPA. We'll see
Okay.
what the IV access is.
Okay.
The other thing we want to do is have like an active check.
Sure, yeah, I'll get on that.
Okay.
All right.
Thanks.
So,
So.
I know it looks pretty dead right now. If we need help at any point, we can always grab some more text.
Okay, that sounds good. Yeah, so, all right, here we go. So I think you guys are gonna be right over here. How are we doing?
Hey, we've got a 73-year-old male with weakness on his left side, right-sided facial droop, white set happened 3 hours ago. This happened last week, but it lasted an hour and more away. He's slurring his words, but answering questions for us. We got blood pressure 155/80, heart rate 85, respiration 16, temperature 36.5, 110 glucose.
110 glucose, okay, great. What, that blood pressure one more time?
155/80.
We're gonna move over here. Everyone ready on 3?
1, 2, 3. Okay, sir, how are you? Can you hear me? Hi, I'm Dr. O'Connell, nice to meet you.
I'm gonna get you hooked up to some of our vital sign monitors,
So
sir.
can you smile for me? Good. Can you open your eyes? Can you tell me your name?
John. Jordan.
Okay, John. Can you tell me your age?
73.
Okay. And can you tell me what month we're in?
April.
Okay. So good. Well, do you have stickers?
I'm gonna get some leads here.
Okay.
In a second,
Great.
John, and then we'll get the monitor up and running.
Yeah, this is
It's like on the blood pressure. Looks like
Okay.
it came back pretty high.
this is an optimal time if we can call in people.
Yeah. Can we get some help in here,
We
please?
just want to get an IV started. Okay, a couple of other things for you. Can you open your eyes? Good. Can you close them? Good. Close them real tight. Good.
Okay,
Okay.
help us get an IV going.
Can
on
you
this one.
move this hand for me? Good. Can you lift it up? Good. And we're working on blood pressure.
Blood pressure cycled 194/93.
Okay.
We've got a monitor up here,
You can bring your
One of
hand
these
down. for me.
fancy,
Thanks so much.
non-invasive continuous blood pressure monitors looks like, so we gotta wait for
Do you
that.
have family? Do you have family that was there with you?
My wife.
Your wife, and this happened right before you came in today?
No, it happened like 3 hours ago.
3 hours ago, okay. Do you take any medicines?
Yeah,
What medicines do you take?
I take aspirin
An aspirin?
and metformin
Okay,
and Tugboat.
okay, can you lift this arm for me?
No.
Okay, you sure you can't? I'm gonna try to bring it up here, can you keep it up there for me?
No.
No, okay. All right. So we're also gonna do this, we're gonna get another finger stick just to make sure.
Sure.
Can you lift this leg up for me? Good, okay, can you lift this leg up for me?
That went through my.
Okay, I'm gonna bring it up, Can you keep it up there for me?
No.
A little poke on your finger, sir, to check your blood sugar.
Okay. Just so everybody knows where we're at, this gentleman, John is your name,
Yeah.
last name?
Jordan.
One more time,
Jordan.
Jordan, does that sound right?
Yeah.
Okay, so Mr. Jordan is has dense paresis on the left side. I'm a little concerned that he's having a stroke. Can you stick out your tongue for me? Okay, can you open your mouth? Okay, any headache at all?
No.
No, okay. So, well, I didn't catch the finger stick. What was it?
It was 91.
91, okay, great. So, Mr. Jordan, we're about 3 hours, so we're at an optimal time for us to consider maybe doing something to help you with this stroke, okay? So is it possible for us to get a CAT scan?
Let's take them off the gas.
Yeah, let's
right
do
away.
that. What I'll do is I'll call the neurologist.
Okay.
So are we at ABEM General?
Well, this is one of those rural hospitals. So we're
Okay.
gonna- But we have somebody that we can call for sure. We
That's
can try and
fine.
Get them on the line, I can try and get them on the line.
In the meantime, if we can
Would
call
that
the
make sense?
pharmacy and get a
Yeah.
TTA, that would be great.
Absolutely.
Okay. Okay, Mr. Jordan, we'll see you when you get back. I'll try to get your wife's phone number. We can have somebody maybe give us a phone number, we can reach out. She's somewhere nearby, okay.
All right, we're gonna take him to
All right.
the please.
So, let's see, so just we're waiting for him to go to CT. We're gonna see if he has a bleed, TPA if need be, get neurology on the phone, probably, so we're a rural hospital. I suspect we're gonna have to.
I've already asked him, to at least call them to get the ball rolling.
Okay.
But, I mean, it looks like he's protecting his airway okay.
Yeah.
It seems like he's still pretty lucid, so.
I think so, yeah, in terms of like, he's.
We have another EMS dispatch coming in.
Okay,
Rings of
go ahead.
This is DC Fire to Hospital 8.
Yep, DC Fire, this is Hospital 8, go ahead, please.
We have a 56-year-old male with substernal chest pain. EKG shows possible STEMI in the anterior leads.
Okay,
Our vitals are as follows: blood pressure 170/93, heart rate of 100, respiratory rate 12, temp 36.5. We've given aspirin, so ET's about 4 minutes.
okay, 4-minute ETA, sounds like, great, we'll see you when you get here. So this was maybe a STEMI?
Sounds like.
Okay, so this is one of those things where to be honest with you, I'm not gonna remember the dose.
Okay.
Since we're at a rural hospital, I'm gonna look up
For sure.
whatever our doses are for TPA.
Sure.
But it seems like both of these patients may end up needing TPA.
Yeah.
I
The good
know
news is-
we're fairly new here, but is this one of those hospitals where we can fly people out quickly?
So they just recruited this really great new interventional cardiologist, we spent a ton of money on our cath lab.
Oh, great.
So hopefully it's a situation where you can come in, kind of figure out what's going on. and
Awesome.
get things.
Why don't, is it possible for us to get cardiology on the phone just to let him know that we may have a STEMI?
He's not technically on call, but let's get him in and then we can see what's going on. Sometimes it's a little angry if you call him. That's not what we really need.
Listen, I'm not about people's feelings.
I know,
I'm about the
I'm just
patient.
saying, you screamed at me.
There he is.
Do we, I guess hi, sir, how you doing?
Oh,
Hey, everyone.
oh, my chest is killing me.
I'm sorry about that.
Oh,
Let's do this. We're gonna just get the information from EMS. I'm Dr. O'Connell, and let's hear about what's going on with you, okay?
feels like
I
an
have a
elephant sitting on my
56-year-old
chest.
male with substernal chest pain starting 2 hours ago.
Oh,
He has a past history of hypertension and cholesterol problems. He's diaphoretic, and his pain's radiating to his left shoulder. Blood pressure 170/93, heart rate 100, respiration 12, temperature 36.5, and glucose at 100. We gave him aspirin, nitro, and 4 morphines.
you got it.
Thank you so much. Hi, sir, how are you?
Us.
Dr. O'Connell, this is our care team right here. So we're gonna get an IV started,
Yeah,
and we're gonna do an EKG right now. Do you know?
Yeah, we're doing a
what
12 lead
Do you have
EKG.
the EKG in the Kmart?
I can go grab it for you.
Okay.
I'm grabbing it totally right now, okay?
Okay. Watch your hands.
oh,
We got nitro and aspirin.
Yeah. Okay, we're gonna move over here and got this. Listening, we're moving over to new bed, sir, okay? Let's make sure this screen is locked. All right, on 3, 1, 2, 3.
oh.
There we go. Okay, come on over here. All right, so we're gonna get a new.
Okay, back on
We're
monitor,
a
we're
little-
gonna get an EKG.
Perfect, yeah, let's get his blood pressure.
Yep.
A little concerned you might be getting having a heart attack, okay? We have nitro available.
I'll pull some out.
I don't wanna give it yet, I'd like to get our blood pressure first before we do that.
Okay.
Have you ever had any heart problems before?
No, I've never had it.
Never, okay. And
Oh.
do you take any medicines or have any allergies?
High cholesterol, hypertension,
Yeah, do you know what you take for those things?
penicillin, I've got it.
This is our EKG.
Oh, yeah, okay, looks like you're having a STEMI, okay? So a STEMI is basically where your artery is blocked completely, and we need to get blood back flowing to that part of your heart. One of these days, I'm gonna learn how to speak properly. But the key for us is to see what your blood pressure is, and then for us to get the medicine. So how much do you weigh? 190.
Yeah.
Okay, and when was the last time you weighed yourself?
Last week.
Okay, very good. And do you have any allergies?
Penicillin,
Yeah, and then smoke?
I don't know.
Okay, drink alcohol at all.
Yeah, I have a couple of years, so.
So I do want to
Oh.
talk, so I want to talk to you about this. If we give you this medication, there are some risks associated with the medication, okay? So I do want to ask you, have you had any recent surgery or any head injury?
No.
Okay, ever had any bleeding, or do you have any bleeding right now?
No,
Either
not
blood in
really,
your
no,
stool or in
no.
your vomit?
No,
Hey, sorry, John, I am getting the half up on the line. They say they're spinning up their thing. You want to send them over there?
Oh, yeah, if we can get them right to the cath lab, that would be phenomenal.
Okay, so,
Oh.
okay, yeah, well, we just called a cardiologist in, great, thank you.
So we have a blood pressure, can we give him a sublingual nitro?
Sure.
Let's see if we can get some of his chest pain going. We have an IV started?
Yep.
Great. I don't think we need to give any fluids right now, but we'll give him nitro and then just have fluids available in case his pressure drops.
A little bit of medicine for you, we're gonna put under your
Just
tongue
gonna be
here.
under your tongue,
Good,
okay?
okay.
Alright.
All right, we're gonna get you packed up here, sir. We're gonna get you headed out to our procedure room.
I do want to ask you a few other questions as you go. Any pain that radiates to your back, any belly pain?
it's just up in my shoulder,
Up in your
and
shoulder?
the pressure on my
I'm
chest.
sorry, but
Oh,
quickly, how is the nitro working on your tongue?
Feeling a little better, sir?
Alright, we'll get you going, okay, and they're gonna take you upstairs. Thanks so much.
The side rail up here. We're gonna put this little cap on you. You're kind of going into like a surgical area, so we're gonna keep your, your head nice and sterile there. Awesome. All right.
Oh, alright,
Well, one right after the other.
it's a busy day.
Yeah.
You know, I'd say this is an emergency medicine day, but most of the days are a little back pain, so.
Yeah, I wonder what's going on with that. Let me see if I can get the radiology.
Yeah, we haven't seen our guy.
It doesn't matter. Yeah, so let me see if I can get
Oh,
this.
is this him coming down the
This
hall?
might be him.
Okay,
You guys coming in from radiology?
great. Do you,
All right,
can we get the radiologist on the phone? I wanna know if they've seen it.
Looks like they gotta check an armband first real quick.
John Jordan, okay? All right, John, are you awake? All right, are you able to open your mouth for me?
So can you call on radiology and see like what's taking that?
John, can you tell me again your age? Okay, good. And do you know where you are?
Hi, this is Dr.
He seems kind of like he's a little more under than he was when he left us.
John, can you close your eyes for me? All right, let's get him hooked back up.
Yep.
Okay.
Seems like there's radiology's having some.
Well, John, we have a no free show policy here. All right, so John, can you hear me?
yes.
Okay, can you stick out, okay. Good, okay, you can cough a little bit. All right, I'm just gonna quickly,
Exam.
all right, do we have an answer back from radiology?
The radiologist is saying that he's having trouble seeing the exam on the screen.
He can't see anything?
He can't see.
Just getting some suction.
All right.
He's not even seeing the.
So let's do this. We're at a tight window, okay? John, listen to me. So I don't know that we're gonna get this read back in time, okay? So the issue is that can we even pull it
I think
up?
he's trying to ask for a
We
little
can't
bit.
even look
I
at
think
it.
he's
All
trying to
right,
ask for.
John, what we're gonna do is we're probably gonna need to put you in what's called a medically induced coma. That means we're gonna give you some medications, okay?
Perfect. I'll get you some.
No, just some blow by, you don't have to bag. We're gonna give you some medications. Can we have,
What do you want?
let's see, I don't have a pressure on him, but his last pressure was high.
Yeah, let's
So
cycle one
that's,
more
so
time
that's
here.
fine. We can do etomidate, so
Okay.
25 is etomidate.
Okay.
And then, I don't recall it being any issues, but you know what, just to be safe, let's just do rocuronium.
Sounds good.
We'll do about 60, you know, he's kind of a big guy. So let's do 80 milligrams of rocuronium.
Okay.
All right, I'll get set up, make sure that
Yeah,
but
but
it works.
his blood pressure is pretty high, so.
All right.
Got that in
Thank
too.
John, so I don't know if you can hear me, all right, but, yeah,
Coughing a
but
little bit here.
we're gonna end up intubating you, okay? So I'm just gonna keep this on and then, sorry, I forget your name.
Yeah, no problem. I'll push your button for you when you get spot.
No, is it Jeff though?
Yeah, yeah.
Okay, Jeff, when you get a chance,
Yeah.
let's 20 of accommodate, okay? And then, yeah, perfect. And then
Attention clinicians, we're experiencing an unexpected downtime of the EMR and PAC system. Please transition to paper charting until further notice.
all right, do we have, what we're gonna need to do is get his wife on the phone.
Okay.
The main thing is we have to decide whether or not we're gonna give him TPA. I would say at this point, we have no knowledge. The first rule, what's the first rule? Nobody talks in Fight Club. No, the first rule is we don't do any harm. So I don't know that we're gonna give him TPA.
Okay.
When you're ready, let's do this. Let's focus on the airway, do one thing at a time. When
Okay.
you're ready, let's give 20 of accommodate.
We got your tube and your foot pump
Yep,
there.
you have two ready to go. Do we have, perfect,
Pushing the 20 accommodate.
great, that's in,
Okay.
Okay.
Rock around is going in.
perfect. So we're gonna have to wait about a minute, minute and a half, 2 minutes. We'll see. Let me see. Yeah. Jaw laxity. Okay, so respiratory rate's gone.
Yep.
Sad,
Starting to
okay.
reset a little bit.
Alright, I'm gonna bag him a little bit.
That really is a little weird too.
Yeah, that's a little crazy. One thing at a time. Alright, as soon as we get him intubated, what I'd like to do is get him hooked up to the pads. See
And we
what's
can-
going on.
We can also send him, once he's intubated, the ICU will probably be ready to accept him.
The question will be TPA, I think at this point, without any knowledge, can't do that. I can't even look at
Yeah, like that, yeah. Let's get the breathing tube. If something weird just happened, so I'll have to take a look at that.
when you say something weird, that's
Something weird on the computer, but let's get the breathing tube in.
Can I have you pull down this look a little bit?
Grab a cookie too, that might help.
Here, just hang on. No, you're okay.
I think you're in. Yeah, I'm just gonna take a shot out here, yeah.
Okay.
Here.
Alright,
Stop.
balloon is up.
Good, nice test rise, good color change.
Perfect.
Great.
Okay.
All right, keep doing this, can we just wrap a little bit of secure that tube real quick and then we'll,
Okay.
let's,
So you were saying that the ICU might be able to.
yeah, let's get the ICU on the phone and see if we can, get him transferred over.
Okay, so
Because we still got other.
can I talk to the intensivist?
Yeah, this is Dr. Sumser with critical care. Go ahead.
Yeah, hey, this is Fran O'Connell. I'm down here in the ER. We have this gentleman, Mr. Jordan. He came in, he's hemiparetic, concerning for a stroke. He was within the window, but we can't see his head CT. We're really at a point now where he would get TPA, but I honestly, without being able to talk to him, am a little concerned about giving him TPA. So what I'll try to do is get his wife on the phone to talk to her, but I think that at this point, it's gonna be just conservative management and blood pressure management. His blood pressure is 198/91, so it's certainly possible. It's a dry stroke, but it could be a bleed. I know we're in a rural hospital and I know it's a little risky, but I also think in this situation, his best bet is for him to be in an ICU setting.
Yeah, that's a tough situation.
Yeah.
I had to take him.
Okay.
All right, let's get him ready to go.
All right. Let's make sure he's on the floor. Hang on.
All right, thanks for that.
Okay.
I mean, the computer just started showing these weird.
Oh,
flashing screens.
oh my God, okay, well, let's do this, so can we get the administrator on call for the hospital?
Our patient should,
Can anybody, the unit secretary, can they hear me?
let's figure out what's going on
Let's see
here.
what's going on with the.
Yeah.
Do we even have
You
cell
still have
phones?
I don't even know if laptop's working. This patient might get back to us.
Okay,
Okay.
No.
Yeah, they're back to cath lab, yeah.
okay.
You guys able to
Hey, guys.
do anything for this? Like, what-
We're able to-
What was
It's
this?
a cardiologist
Does anybody
here.
know?
No, they said we couldn't do it, I'm not sure why.
Okay, well, so you guys know there's some problem with radiology, I don't know if they.
Radiology.
Hey, this is Dr. Sullivan, cardiologist.
Yeah, hey, Dr. Sullivan, cardiologist.
Hey, sorry, our cath lab is down. We can't take care of this patient.
Okay, so, was it that you couldn't see anything that was going on, the radiology was down?
No fluoroscopy, no
Uh-huh.
labs, no records.
Okay, so.
And I gotta get back to the golf course.
Hang on, before you go, my plan was to give TPA to the patient then, since we can't do a cath, are you cool with that?
Yeah, that sounds good. It's up to you guys.
Well, I appreciate your support.
Getting back on monitor.
Okay, great. Are
Let's
you
get
getting
him,
blood
sir.
pressure? Can you hear us?
In a lot of pain.
Okay.
Heartburn to talk.
Can you?
Yeah, I can hear.
Oh, great, okay, so I have to explain this to you because we're in a situation where there are a lot of things that are not working because they are connected to the computer system, and it appears that there's some sort of cyber attack going on in the hospital. So the reason I'm explaining this is they can't do your catheterization because they cannot physically see where the blockage is. In that situation, what we would do is give you medication to help free the blockage up. The medication comes with some risks. The largest one is to have uncontrollable bleeding. That the most dangerous one is in your brain, but you can also have bleeding elsewhere. Do we have all our IDs done?
Our monitors are on, I'm finding a needle
Okay.
cannula to get it back up on some
Great.
oxygen.
Now, his blood pressure is pretty high. I'd like to try to give him a beta blocker. Do you have 20 of the beta blocker? Can you do that? Great. So we're gonna try to give you some medication to get your blood pressure
Get a
down.
oxygen mask here.
One of the risks that happens when we give you this medication is that it can cause bleeding, and the higher your blood pressure, the more likely that is to happen. So we need to get your blood pressure down.
My chest is still.
I know, you know what we can do is we can also give you some nitroglycerin too. So let's have a nitro.
Okay.
And then 20 of labetalol IV.
One other thing.
Yep.
We typically, when we do this, we have to get it from the fixer cabinets.
Let me guess.
Let me just check the pharmacy.
Let me see,
I just want to.
That's okay.
It may be a little.
Positive thoughts,
Okay.
serenity now.
Okay.
I'm
So,
gonna get 20 of Labetalol.
yep, that'd be great.
Easy for you to say.
Yeah, when you're done with that, do you mind grabbing the nitro, put it under his tongue?
Will do.
Okay, thanks.
We can see if I can get a needle on
All right, tell me your last name again, sir.
Reed,
Reed, Mr.
Dan
Reed.
Reed, yeah.
Okay,
Little poke here, sir.
gotcha.
Mr. Reed, I'm gonna be putting a little tablet, just like last time, right under that tongue. I just want you to leave it there.
You
Let it
should have
dissolve.
some continuous blood pressure monitoring here in a second. Okay, great. All right, good.
We should at least let still.
Yeah, all right.
All right, so Mr. Reed, so did we find out if we can get it from the
I'm
patient?
ready to hear back.
Okay. So for you told me that you weighed how much? 190, I think is what you told me?
190.
Yeah, okay. So what we're gonna do is, we're gonna give you some medication. I told you that the risks, are bleeding. Those are the biggest ones. One of the if you develop bleeding in your brain, what we do is get a CAT scan, and then we would need to transfer you out of here. That's about, I would say it's about, the benefit for you is, pretty substantial. Most people do well with the medication. I don't know that it'll clear the blockage, but it's really the only option we have. The risk, of course, if we don't do it, is that there will be permanent damage to your heart, and or you could go into cardiac arrest, meaning your heart not beat properly, and then we'd have to start CPR, and I really would like to.
We're starting to see a little bit of a drop in the blood pressure. I don't know if that's the
Okay.
lateral or.
Maybe
what's going
both.
on.
Okay, can we just have some fluids ready to
yeah.
go? But we're good. So we're gonna give you this TPA, okay?
The steps are going down a
So
little bit too.
we're gonna do, oh, great. We're gonna do, so I wanna ask for your permission, is it okay for us to give you this medication?
Yes, just take care of this.
Got it,
His
okay.
blood pressure is still dropping.
All right, so, let's give, this is the A line, I can see the
Okay,
difference.
yeah.
All right.
I'm gonna have a pulse.
Okay, let's
No
put the
pulse.
pads on, I'm gonna start CPR, and I'll start
CPR.
Okay.
I'll get things ready for intubation.
Sure.
I guess enough
I'm
to
just
do.
gonna, take this, yeah.
Can we get some more help in here, please?
Yep, when they get a chance, that's great, thanks for calling for help, Jeff.
You helping here?
Yeah,
we're
you
just,
might throw on
CPR
some gloves
progress.
on, I just need you to do some chest compression.
Yeah.
Great, we got the airway ready to go.
Yep,
Perfect.
what other meds can you do, doctor?
Sure, just some epinephrine for
Okay.
now.
Epinephrine 1 milligram going in IV.
Okay, and then, when we're ready, we have them hooked up.
You took that? Yep.
Okay,
You have full 15 moment.
yeah, I wanna see his rhythm as soon as we're ready. Are you ready to go? Okay, can we,
Epinephrine's in.
great, can I just see? Okay. Now I'm gonna stop compression, we're gonna check the pulse. Okay,
No
so it
pulse,
looks like we're in V-fib. Yeah, that looks V-fibish. Anyway, charge me up to 200,
Okay.
okay? All right, sure, when you're ready. Okay, are we charged up?
Not yet, we're getting there.
Okay,
I'll let you know we're ready.
okay. Hang on just for a second. Everybody clear? Deliver a shot?
Okay,
Okay,
shock's been delivered.
great, let's continue. You ready? Okay.
Right.
Yeah, so none right now, I just want to get him intubated. This guy's much easier too. Yep. 2 minutes.
Cup is up.
Good, breath down, good, good, okay. All right, when you're ready, can we get, Mike and I think that not amiodarone, or, yes, amiodarone, yeah. I don't know, I see an amiodarone, good thing that we get these things, so, do we have, good inline CO2?
Yep, we've got that. Looks like the CO2, it's not showing up here, but it's probably around 10 to 15.
Okay, great.
We're doing good CPR.
So when you're ready, you're gonna get 300, ready to go,
300
all right?
milligrams of amiodarone.
Yep.
So,
Okay.
hey, you just wanna hold it for the next until we swap, good, okay, give the amiodarone.
Okay, 300 of amiodarone going in.
Good, okay,
Okay.
so Jeff, I'm gonna
Yep.
sing Staying Alive, and I just want you to, staying alive, so a little slower, okay, there you go, that's perfect, awesome. Okay, great, so let's get another milligram of epinephrine going on.
Okay, 1 milligram of epinephrine.
We're about 2 minutes, let's hold, we don't have anybody timing, I'm just going off my rep here.
Holding CPR.
Okay, I don't have a pulse, let's do CPR, charge me up to 200, please, don't worry about the medicine. Okay, I'm gonna take over bagging, I want you to draw up 60 milligrams of TPA. Okay, and we're gonna infuse that.
We have any med card? I think it did just get dropped off, yeah.
Yeah.
You have that already?
I have it,
Yeah, it's right there, pharmacy page right there.
Yeah. Actually, let's do this, I want accelerated infusion, so we'll do 15 milligrams. So drop 15 milligrams of
Okay.
IV and let's get that bad boy. That's just gonna go in.
Should we talk to you guys?
Yeah, are we ready? Great,
We're
thanks for
ready.
reminding me. Okay, shot,
everybody
everybody clear?
Okay,
The
Shock has been
delivered?
delivered.
Okay, let's keep compression.
I think I actually have a little bit of a pulse.
Okay, hang on just for a sec. Well, technically the algorithm
Keep
calls
going.
for doing compression, so.
But yeah, I do feel a good pulse.
That's good, okay. So let's do this, let's get a little bit of fluids ready and an epinephrine drip.
Okay,
Okay.
sounds good. Do you still want your 15 milligrams of TPA?
Oh, that's wonderful, that I still have you extending. Let's switch so you can get, let's hold on. Alright, great.
Do you mind hanging there?
Yeah, we got a pulse. Yep. Okay, so let's just review quickly. So now we have Ross, all right? He needs blood pressure support. So is this his blood pressure 104 or 82? Okay, so let's just run a little bit of slow fluids through him. Let's do 15 milligrams of TPA. Was that given yet?
No.
Okay, that's fine. Let's do 15 milligrams IV. It's gonna be a slow push.
Okay,
And then we're gonna hang 50 milligrams after that. But for now, 15 milligrams slow IV push.
okay.
Okay, great. And I think
And the epi drip, do you mind setting that up?
I think the ICU is calling back up
Yeah, no.
too.
great. When we
More to do.
Yeah, can we this guy transferred?
Okay.
Yeah, we got Ross, yeah. I can talk to him, it's okay.
All right,
It should be in here in a second.
great. So once that's done, the next thing you're gonna do is drop 50. Okay,
Okay.
we'll keep a tab on the.
Hey, this is Dr. Selzer calling from the ICU again. I got a call.
Hey, what's up, Dr. Selzer? It's quite the day in the neighborhood. So we have a gentleman here, oh gosh, does anybody remember his age?
56, I believe.
56-year-old guy, prior history of hypertension, hypercholesterolemia, came in with a STEMI, was sent up to the cath lab and they sent him back because they were unable to do the cath because we're having issues, I think you probably know this, with radiology and with various systems of the hospital. He subsequently coded before we could start to get a TPA infusion going. We've intubated him. His blood pressure is 104/82. His heart rate is 103. SpO2 is 97. We're breathing about 15 for him. And he got the first dose of the accelerated infusion protocol of Alteplase. So he got 15 milligrams, and we're getting ready to hang the 50 on him. Because he was coding, I elected to give him the TPA. So I was not able to. We talked a little bit about it. He did agree that it would be good for him. We talked about risks, benefits. So. But you know, it sort of the conversation tapered off when he coded, which was unfortunate, but given the circumstances, thought it would be appropriate. Anyways, so I'd like to get him up to the ICU where I think he'll do better there.
Man, we've been having a rough day, but it sounds like you've been having an even worse day. You gotta take him.
Okay, great. Thank you so much. We'll get him up there shortly.
All right, let's get
All right.
this guy transferred.
Great.
And the 50 milligrams of TPA.
Great. So you're gonna hang on just for a sec. That's gonna get hung up. It'll be over 30 minutes.
30 minutes,
We,
okay.
yeah, we can start it now and just let the ICU know.
Sure, I'll put it in with the
All right.
infusion.
Ready to roll
All
out?
right, thanks, everybody. That was quite the, here, hang on, he's still hooked up. Hang on. There you go. Okay, we're good. All right, all right.
Yeah.
What do you guys think? Reactions? Yeah, let's get, I didn't do anything. I just, thank you for, give yourself a round of applause. So like I mentioned, it's an experiment. You never know what's going to happen. We're going to have an opportunity to ask some questions, get some response from the physician who just underwent that. But were there any questions about what happened? Yes.
Expected. Would that have affected, if you didn't have that, would that have come?
Great question. The question is, the physician pulled out their phone to do a calculation about a drug that they don't give very often. It's not rare that we give these medicines in the emergency department. It is rare, however, that we give that medicine for this circumstance, and the doses can change. And so we rely on a whole cadre of additional, forgive me, We rely on a bunch of external information. Typically, it used to be books they put in the doc boxes. If you had a reference, you had to look up something, there'd be a whole just tomes of books you'd look up. Nowadays, we look it up on our cell phones. We have applications that help us remember how to perform during a code or give a certain medication or a certain antibiotic at a certain dose. Your question as to if that was unavailable, would that have led to something unfortunate? Possibly. The other resource we use often are online resources our institutions subscribe to. Hopefully that's. And those will go out if the internet goes out. And so long story short, there's so much information to know in medicine, you can't memorize it all. You have to rely on these outside resources. The last 10 years since smartphones, more than that, since smartphones are really taken off, those have gone into our pockets. Yes.
In the way that you're describing about applications, can that, like a whole cell phone ecosystem, does it exist where you can have complete redundancy on your phone?
So the question is, could a cell phone or a tablet replace the electronic health record and other types of clinical systems if they were to go down? I'm unaware of any type of fail-safe mechanism like that. Now, there are niche circumstances. How many people have heard about this thing called the cloud? I grew up in Arizona, so they didn't, like, water used to fall from them, I heard, but I haven't confirmed that. But the cloud migration has led a lot of institutions to put their electronic health records into the cloud. And that would offer an opportunity that if your local network's down, you could potentially still access your electronic health record from an endpoint that hasn't been compromised or infected. That's possible. However, there are a lot of details, devils in the details. And not to get technical, but how does your AD work? How does your authentication work? If you're doing your AD locally and you're trying to authenticate to a remote, it depends on your system. But the heart of it is, what systems exist to replace lost clinical functionality like that? There aren't. Unfortunately, let's go back to paper. It's pull out these tomes of paper, write your orders down, go everything back to manual. There was a question over here first. No? Okay. In the back?
That would seem like tax was the only thing down, but I would see that like pharmacy would be a huge issue, right? So you would order that med, but they would have no way to verify it. How would it even get there? So I think this was bad, but like not nearly as bad as I think it would actually be.
That's a great insight. So we selected to have the electronic health record out, the PACS system, which is an imaging system we use to look at chest x-rays and CTs. It's software used to view those things. You bring up the whole host of connected medical technology and software that supports patient care, including things like pharmacy. We order drugs, they go to the pharmacist to verify that we've ordered the right drugs and we're not going to hurt somebody. All that goes through the electronic health record and some other ancillary systems. But you're right, it could have been so much worse. We could have taken down the telephone systems. So imagine trying to talk to the doctors who are going to take these patients into the ICU. Imagine trying to talk to the cardiologist and your phone systems don't work. Those specialists need to come in timely and help those patients. They need to take them up to the ICU. There's so many other systems that we didn't take down in this example that would have also impacted patient care. Great insight. Yes.
Typically, there will be someone like in the room taking notes on what's going on. Would that person be empowered enough to say, hey, something's up with EHR? And would that have made a difference?
So the question is there someone in the room that's taking notes that can communicate those types of concerning findings on the screen? Hey, I think we've been ransomed, and would have communicating that earlier helped? I think that there is someone who's designated during a cardiac arrest event to document. Does that always happen? Most of the time it does. In certain chaotic circumstances, there may not be someone, but there should be. They document when certain drugs are given, when there's a rhythm change, they're supposed to keep time. So they can tell we need to stop compressions and do a rhythm check, for example. In this case, the die is already cast. The systems are down. Knowing that they were ransomed earlier probably would not have changed anything. They still would not have been able to look at the CT scan to know if they should give that patient that's having a stroke medicine. Still would have taken down the cath lab so that patient couldn't go upstairs and get that cardiac intervention. But great thoughts about, speaking up in a culture of medicine when you don't see something right. This is a common thing we talk about at CyberMed. So when you see a device malfunctioning, are you empowered as a nurse, as a doctor, as a resident to say, I think this device is acting up. I want to raise questions about what that is. And to our knowledge, we've never seen a live compromised medical device impact patient care, but it would require that type of open, honest communication, being able to talk about those issues and raise them for us to even, as a prerequisite to us identifying them. Oh, yes.
The blood pressure machine, and I'm curious, I mean, part of it, you have a right? But no one, I didn't see anyone ever like wanting to verify the blood pressure physically. I'm just curious if that does your comment. Now starting to figure out what else could be going on.
Great question. It's that the blood pressure was dropping. Did anyone manually verify that? Did they pull out their stethoscope, put on a blood pressure cuff and check if that patient's blood pressure was low? I like that question for several reasons. The one is, you saw how chaotic it was, but this is a controlled environment, right? These are mannequins, these aren't real people. It is way more hectic than that in a real code. A code like that during a ransomware event, mayhem. The ability for someone to question and then verify if that blood pressure is accurate, it's just not going to happen. If your system's working, it's taking the blood pressure, everyone in that room will likely implicitly trust that number unless it's way out of line, right? So if the patient's talking to you, they look well perfused, they don't look like they're in distress, and the blood pressure monitor says they're dead, that discrepancy would cause someone to pull out their stethoscope. But if it looks consistent with what we were seeing, I guarantee you, implicitly trust it. The other reason I like that question is because it talks about integrity attacks. For the longest time, we've really worried about patient health information, confidentiality, privacy, breaches of the record data itself. There's a whole reason for that. HIPAA laws, et cetera, fines, the wall of shame. That's really important. What you're talking about is a potential for an integrity attack. Can we trust the information that we are seeing? Be it vital signs, be it images from chest x-rays or the EKG. All of these sources of information we implicitly trust, but the opportunity, I don't want to say opportunity, the threat of an integrity attack, wow, that could be quite devastating because I mentioned how much we trust them. It wouldn't have crossed anyone's mind that that blood pressure would have also been altered, that maybe we couldn't trust the laboratory studies that were coming back if they ever came back.